Hello, my name is Benjamin and welcome to Med One Pager. Today I'm going to be looking at spinal cord disorders and syndromes, and I'll try to cover most of the high yield facts or high yield information you need to pass your exams. But I won't promise to cover everything there is to know about spinal cord disorders, and it's a very complex topic with a lot of things to put together. The anatomy is very relevant, and as well as them knowing how these things connect with each other and how they work. But I will try to simplify it a bit, explaining the baseline information that you need to build on a very strong foundation when it comes to spinal cord disorders. So we shall begin with reviewing the relevant anatomy of the spinal cord. So the spinal cord has both the white matter and the gray matter, and the gray matter is found in the middle of the spinal cord, as the white matter is found on the periphery. And the gray matter is made up of the nuclei, while the white matter is made up of the nerve fibers. And when these nerve fibers come together and combine, they're going to form the tract. So in the white matter, we're going to find the different tract. Now, in the spinal cord, we have the ascending tracts that are bringing information from the peripheral organ or from the peripheral nerves, the fingers, the hands, the legs, going upwards. And we have the descending fibers that are bringing information from the brain coming down. So you think about the spinal cord as a relay, as a main line coming from the central nervous system, also being part of the central nervous system either way, but it is going down the body from the brain, going down and giving off different parts of it, giving off different nerves to pick and bring information to those different body parts. So I will not take you through the whole anatomy of the spinal cord because that will be very confusing, and that should actually be a video of its own. But I'll try to look at the important ones that we always need to identify the spinal cord disorders on examinations or clinically. So when we look at the ascending pathways, I would like us to think about the dorsal column, and that is in the posterior aspect of the spinal cord. So the dorsal column is going to be responsible for taking information up to the brain, information about vibration, proprioception, which is the position of your muscles. It tells the brain, oh, my hand is on my waist, for example, or my hand is touching my head, or my right leg is in front of my left leg. That is proprioception. And it is also going to help with fine touch, which some people call the 2-point discrimination, something like that. And fine touch is going, so together the dorsal column is going to help you with what you call discriminative touch. It can sense the vibrations, the proprioceptions, and the fine touch. Then we go to the spinothalamic tract. So it has two words, spinal and thalamic. So it's from the spine going to the thalamus, and the thalamus is actually the relay center for all sensory input to the brain. Then we have the corticospinal tracts. Now these ones are going to come from up, going down. They are descending tracts, and for them they are going to control the motor functions of the muscles. So we have looked at the dorsal column, the spinothalamic tract, and the corticospinal tract. These are going to be very important in identifying the spinal cord syndrome, as well as identifying or localizing which area, because when you look at them, the dorsal column is in the posterior. The spinothalamic are anterolateral, so they are kind of in the sideways. Then the corticospinal tracts are found in the anterior. So when you look at the blood supply of the spinal cord, the blood supply is going to come from the spinal arteries, and we have the anterior spinal artery and the posterior spinal artery. So the anterior spinal artery is going to supply the anterior 2/3 of the cord, and the posterior spinal arteries are going to supply the posterior 1/3 of the cord. So you see that if I have an infarction of the posterior spinal artery, I'm going to have the posterior part not receiving blood. And what is in the posterior part of the spinal cord? You got it. That is the dorsal column. And when we look at this anterior spinal artery covering the 2/3, so anterior and the lateral and the laterals. So if I have a problem with the anterior spinal artery, what is going to be having the problem? That's going to be my corticospinal and the spinothalamic. So I think you see how the things come up. Then another important concept to master when it comes to the spinal to the spinal arrangement or the spinal nerves is going to be the parasympathetic and the sympathetic. So the parasympathetic has what we call a craniosacral arrangement. So the parasympathetic nerves are going to come from the cranial nerves, which have their nuclei in the brainstem, as well as come from the sacral nerves, which are down. So the cranial nerves 3, 7, 9, and 10 are going to be part of the parasympathetic, and S2 and S4, or the sacral nerve 2 and 4, are going to be the parasympathetic. And these ones are important in things like resting and digestion and things like that. So the parasympathetic is the reason you're not urinating on yourself, is the reason you're not defecating on yourself. So if we have a disruption there, if the spinal cord is severed somewhere and we have loss of those function of the parasympathetic, you can tell what could happen. Basically, bladder and bowel control will be disrupted. The sympathetic nervous system is going to come from T1 to L2, and this one is responsible for the fight or flight, and parts of it are going to, for example, if you look at T1 to T4, we call it the cardiac accelerator nerve, which helps in the increasing your heart rate, increasing your contractility of the heart, and different things like that. So you find that even the pupils are going, when the dilatation of the pupils is controlled by T1, the dilatation of the pupils is controlled by the sympathetic nervous system, and this is going to come from actually the level of the thoracic vertebra and course all the way upwards to reach there. So we have looked at that. Now when it comes, going back to the spinothalamic tract, the spinothalamic tract has something very special about it, in that when you look at the 3 different tracts that we looked at, all of them are going to move ipsilateral. They are not going to cross, or there is not going to be decussation of those spinal tracts in the spinal cord. When the dorsal column and the corticospinal, they're just going to come from up. So the corticospinal, as they come from the cortex, the motor cortex, they reach the pyramids, and when they reach the pyramids, that's when they actually decussate. When you look at the dorsal columns, they're going to come from up, from whatever they come from. The spinal nerve enters the spine and will go upwards on the same side. But what happens with the spinothalamic is that it is going to cross when it is in the spinal cord, but it does not cross at the same level. It is going to move diagonally. So spinothalamic tract is going to move diagonally about 2 levels, and by the time it reaches 2 levels up, for example, if my nerve entered at the level of T4, it is going to cross within the spinal cord, and it is at the level T2 that it will eventually have crossed. So when you have disruption of the spinothalamic tract at T2, the symptoms are actually going to begin at T4, because this nerve, the nerve that is at T2, was actually always trying to move to the contralateral side over the 2 columns, moving diagonally within the spinal cord. So now that we have understood those basic things, we're going to look at some of the way we can approach the spinal cord disorders by classifying them. So we have the traumatic, we have the vascular, the infectious, inflammatory, neoplastic, degenerative, and congenital disorders of the spinal cord. And this is talking a few of them, but these are going to be the most important for you to know. So when you look at the traumatic, when we can have the spinal cord injury, we can have the fractures, and when we have the traumatic injury to the spinal cord, we are going to encounter things like a spinal shock and neurogenic shock. So spinal shock is going to be defined as a sudden loss of all spinal cord functions. Whereas the neurogenic shock is going to come from the disruption of the sympathetic nervous system, which we said comes from the level of the sympathetic nervous system, which we say comes from the level of T1 to L2. So if we have an injury above that level, above T1 or within that area of T1, we are going to have loss of that. We're going to have loss of that sympathetic activity, and the sympathetic activity is important for the sympathetic tone. So we're going to have a massive vasodilation, and that is going to cause the neurogenic shock. And one of the characteristics of neurogenic shock is that we are going to have a decreased blood pressure, and as well as bradycardia, because normally the heart is supposed to increase the heart rate when we're having low blood pressures, but in this case it is not going to because of this. Then when we continue, we are going to have warm extremities, and this is very common and also in spinal in neurogenic shock. Then we have the vascular, and I talked about this. When you have anterior spinal artery, we're going to have bilateral motor paralysis because the corticospinal tract is found in the anterior side, as well as the loss of pain and temperature from the spinothalamic, which is found in the lateral, anterolateral position. Then the posterior spinal artery is going to give us only loss of proprioception, but we have motor preserved. Then we can have arteriovenous malformations, infarcts, and hemorrhages. We can have infections like tuberculosis, and tuberculosis of the spine is called Pott's disease. And this is going to basically cause compression wherever it is, what we call a compressive myelopathy. We can have syphilis, which causes tabes dorsalis, which is basically degeneration of the dorsal column. So you can imagine what will happen when you don't have a dorsal column. Fine touch, proprioception, all that is going to be affected. Then we have HIV-related vascular myelopathy, bacterial viral myelopathy. We can have the inflammatory or the myelinating diseases like multiple sclerosis. And in the moment, I'm going to talk about multiple sclerosis, give you all the high-yield facts about this. We can have neuromyelitis optica, which basically is looked at having a combination of optic neuritis, which is inflammation of the optic nerve. And when we have inflammation of the optic nerve, most of the times we're going to have blindness setting in, accompanied with longitudinally extensive transverse myelitis. So transverse myelitis is inflammation of the cord. And if it is transverse myelitis, it's going to be total inflammation on the whole cord. So we have all the tracts being disrupted, the motor, the dorsal column, the spinothalamic, and everything is going to be disrupted. Then we have the ADEM, which is acute disseminated encephalomyelitis, and this is going to commonly come after provision of a vaccine in a child, or they're having a viral attack, and there's some molecular mimicry whereby the body starts to recognize some of the proteins of the myelin sheet as being foreign. So when this happens, myelitis is going to occur as well as encephalitis. So this paper are going to have features of encephalitis as well as myelitis, weakness, upper motor neuron signs. They're going to have seizures, encephalopathy, and such and such. Then we can go to the neoplastic, which can be intramedullary if it is affecting like the ependymoma, the astrocytoma. We can have the extramedullary like the meningiomas, schwannomas, the extradural like the metastasis, and the lymphoma can also affect the spinal cord. Then we have the degenerative or the metabolic like cervicospondylitic myelopathy. We have the vitamin B12 deficiency. We have vitamin B12 deficiency. Most of the time we have subacute combined degeneration of the spinal cord, and this is going to affect the dorsal columns and the spinal cord, the corticospinal tracts. Then we have the ALS, which is under that we have a motor neuron disease, and this is going to affect mostly the motor neurons only, and we shall retain sensory inputs very intact. Then we have hereditary spastic paraplegia. Then the congenital, we can have things like a spina bifida, we can have a tethered cord, we can have the syringomelia, the Carey malformations, whereby maybe we have herniation of the brain down into the spinal cord as a Carey malformation. So when we look at the syndromes, and these ones are going to be very high yield or very common in exam, we're going to start with one we call the Brown-Sequard syndrome, and this is very important. So this happens when we have a hemisection, or when we have something that this cuts the cord half to only halfway, and this is going to be caused by things like trauma. Maybe someone is stabbed with a knife in the back, and the spinal cord is transected halfway. So what's going to happen is that we are going to have ipsilateral motor loss, because remember we said the motor nerves do not decussate. They do not decussate. So we're going to have ipsilateral motor loss and dorsal column loss, because these are not going to decussate. So we have loss of motor function on the same side as the lesion, as well as loss of proprioception, vibration, and fine touch on the same side. But On the other side, we're going to have loss of pain and temperature sensation. And this is going to be 1 to 2 levels below because of what we talked about, that the spinothalamic tract that is responsible for conducting pain and temperature decussates within the spinal cord or crosses over to the other side, but diagonally along 2 levels of the spinal cord. And that is what causes this thing. And that is the most important thing to know about Brown-Sequard syndrome. Then we have anterior cord syndrome, which can be caused by an infarct of the anterior spinal artery or by trauma. And we shall have bilateral motor paralysis and pain and temperature sensation. But the vibration and perception are intact because the posterior part of the spinal cord is okay, which is supplied by the posterior cord. And when the opposite happens and we have the posterior cord syndrome, which is going to be due to infarction of the posterior spinal artery as well as vitamin B12 deficiency and tabs dorsalis from syphilis, we have only loss of the vibration or proprioception, while the motor and the pain and temperature sensation is intact. Then we do the central cord syndrome, which can be caused by things like syringomyelia, and this basically is compression of the spinal, inflammation of the spinal cord, where all the compression is coming from inside the spinal cord. So we shall have weakness more in the upper limbs than in the lower limbs, and the crepe-like, what they call the crepe-like loss of pain and the temperature. So why are we weak in the upper limbs and the lower limbs? So what happens is that when we're having the corticospinal tracts coming down, the way they are arranged is that the ones that the bundling or the covering of those nerves is going to happen in a way that the bundling is going to be done coming from up going down. So you'll find that as we are coming down, we are piling on more nerves. So the nerves up are going to be inside, while the nerves down are going to be more on the outside. So the nerves on the arms are going to be packed more inside than compared to the ones down. So when you have central cord syndrome and the compression is coming from within the spinal cord going outwards, the upper limbs whose nerves are inside are going to be affected more compared to the ones of the lower limbs. So we get this kind of upper limb loss. We get this kind of weakness more in the upper limbs and the lower limbs, and then the curb-like sensation. Then we have conus medullaris. So the spinal cord ends at the level of around L2, and at that level is where we call that the conus medullaris. So if we have trauma there, if we have a tumor there, if we have ischemia there, we're going to have the conus medullaris syndrome. And this one is going to affect the bladder and the bowel very fast, because remember, whenever you have a lesion up on the spinal cord, everything below is going to get spilled. Everything below is not going to work. So when you cut there, when we have the conus medullaris affected, there's only bowel and bladder dysfunction, and there's going to be pseudoanesthesia because all the nerves that are providing sensation to the perineal area are coming from the sacral nerves, and the sacral nerves are below the level of conus medullaris. This is going to just cause anesthesia there, or loss of sensation there. Then we have upper motor neuron and lower motor neuron signs, and this is very important because unlike the cauda equina syndrome, so cauda equina means horse tail. So what happens is at the end of the spinal cord, like conus medullaris, we have nerves just coming off that tip or that end and exiting through the different spinal, different spinal levels. Maybe remember the spinal cord ends at L2, but we have the S1 nerves coming through the foramina around the level of the S1, below the level of the sacral bone one, like that. So what happens is that in cauda equina syndrome, we're only having lower motor neuron involvement. We're not going to have upper motor neuron signs, and I'll give you a table about the upper motor neuron and lower motor neuron signs, which I will be posting on my social media. You can always go and download it and have a look at it. But what will happen is that we have things like, when we have things like hyperreflexia, we know that is the upper motor neuron sign. Those are upper motor neuron signs. When we have things like atrophy, those are lower motor neuron signs. So there's a lot and a lot I don't want to discuss to make this video very bulky. So what you're going to do when you're approaching the diagnosis of this disease, we're going to have history. Is the onset acute or subacute or chronic? So if it is acute, it's most likely a vascular problem or traumatic issues. If it's subacute, it's most likely an infection or an inflammation that has been taking place and demyelination has occurred. Then we can have the chronic or the degenerative. Chronic, which is going to be degenerative or neoplastic. So on examination, you want to look for upper motor neuron signs, which means the disruption is within the spinal cord nerves or the brain, or the lower motor neuron nerves, which are the peripheral nerves. Then you want to see the sensory level because that will help you localize where the lesion is, and then autonomic involvement. And this is very important because remember we talked about things like neurogenic shock. We can have bladder and bowel dysfunction. This is going to affect your patient very much. There's also some kind of sexual dysfunction because the nerves the parasympathetic is responsible for erection and stuff. So issues they're going to have, you can already tell where that is going to go. Investigations, the MRI is the best for visualizing the cord and the soft tissue, but the CT is better for bone and trauma. And then we can do CSF to rule out these infectious or demyelinating diseases. And then we can do the labs for petrol, for HIV, for syphilis, and other things, and serology. Then management is going to be immobilization, decompression, and surgery if there is compression, as well as steroids. For infections, you want to give the antibacterial, solve the infection. For inflammatory and demyelinating disease, high dose steroids, plasma exchange, as well as immunomodulators. Neoplastic or tumors, that is surgery, radiotherapy, chemotherapy. If it's degenerative, you want to give supplementation like vitamin B12, you want to give supportive care for the pain, for the bladder dysfunction, and so on. Then I promised to talk about multiple sclerosis, and this is around, now we're coming to the end of the video. So multiple sclerosis is an autoimmune demyelinating disease of a spinal cord, of a CNS actually, the brain, the spinal cord, and the optic nerves. So what is going to happen is that it is characterized by a dissemination in space and time, and this means we have different areas are going to be affected. You may have affection in the brain, in the spinal cord, in the optic nerves. So you can say that there's dissemination in space, and dissemination in time means that there's going to be a difference always in time. Maybe we have a symptom now, the symptom goes, that symptom comes. After a while, you're symptom free, another symptom comes up. So that is the dissemination in time. So the onset is around 20 to 40 years, and it's most common in the females and more common in the temperate climates. So what happens is that we have a T and B cell mediated immune attack, and this is going to attack the myelin sheath and lead to axon loss. So in the white matter, where we have a lot of axons, what's going to happen is that we have a periventricular, just around the ventricles, the juxtacortical, the infratentorial, and the spinal cord being affected mostly. And the clinical features are going to be very important because we have optic neuritis, which is most times unilateral, where someone can say, I had become blind in one eye, but then it recovers, and it mostly recovers, and it's always painful. Then we have the motor symptoms, which are going to be weakness, spasticity, hyperreflexia, and these are typically the upper motor neuron signs. Then you have sensory issues like numbness, paresthesia, and Lemite sign. And this Lemite sign is described as an electric-like sensation when we have sudden changes in posture. For example, if we do a flexion of the neck and the patient feels like we have electricity moving down their spine, that's the Lemite sign. Then we have cerebellar, things like ataxia, tremor, dysarthria, brainstem, things like diplopia and ophthalmoplegia, autonomic dysfunction like bladder urgency, constipation, and sexual dysfunction. We can have cognitive of psychiatric issues, and because you have seen MS really affects the brain, so any part of the brain can be affected. So you can have a neurological deficit anywhere, and it has three clinical types. We have the relapsing remitting, which comes and goes, the secondary progressive, where we have a relapsing remitting state, then all of a sudden there's progression of the symptoms. Then we have the primary prognosis, from which there's just a gradual decline from the beginning of the disease to the end. Investigations you want to do MRI, or we will see the Dawson's fingers or the periventricular plex. Then CSF, you see oligoclonal IgG bands in 90% of cases. Then when you do the evoked potentials test, you have delayed visual or somatosensory responses. Management and the acute relapse, IV methylprednisolone. We can give the disease-modifying therapy, which is interferon beta, fingolimod, naptolizumab, and so it's better you actually get something more concrete about multiple sclerosis treatment and you come up with a management, that these are going to be the most important things. Then the other thing is that patients of multiple sclerosis do not like to have warm showers, or they don't like to have changes in temperature very fast. And this is because when this occurs, when we have sudden changes in temperature, they're going to feel a lot of discomfort because the high temperature kind of worsens the inflammation. They feel more pain, so they try to avoid the warm showers. They tell you, if I try to have a warm shower, I don't feel so good. So we have come to the end of this video. There's been a lot to discuss, but I'm glad we're able to do it in less than 30 minutes. So if you found this video helpful, if you think you have understood something about spinal cord diseases, or if you feel that there's something I didn't cover and it's very important, I would be glad if you put that for me in the comment section. So next time I can maybe make a video about it or try to improve how I talk about things. Then it will be very important to me if you leave a like on this video, if you share it with a friend who you know is struggling with spinal cord diseases, and I'll be glad to see you here next time. My name is Benjamin and this is Med1 Peja. Have a nice day.